All right, welcome to this explainer series designed specifically for you, physiotherapists working right out there on the clinic floor with vestibular rehabilitation. Today, we are kicking off part one of our four-part deep dive into gaze stabilization. Our main goal? We're going to unpack the vestibulo-ocular reflex, the VOR, and understand exactly why adaptation actually works. Just a quick note before we jump in, this explainer is based entirely on the clinical review. Gaze stabilization training, principles and prescription, mechanisms, exercise library, and outcome measurement, published by Australian Dizziness clinics. As for our agenda today, we've got four main stops. First, we'll tackle a really common clinical adaptation mystery. Second, we'll get into the mechanisms of retinal slip. Third, we'll cover frequency specificity. And finally, we'll wrap up with your key clinical takeaways. Let's get right to it. Section 1. The VOR adaptation mystery. Okay, so we've all been there on the clinic floor, right? You prescribe what looks like a perfectly standardized list of gaze stabilization exercises, but the results you get back are just wildly inconsistent. Take patient A and patient B. Both present with acute unilateral vestibular hypofunction. You hand them the exact same generic head shake exercise sheet. Patient A comes back in 3 weeks and they're tracking beautifully, but patient B, fast forward 12 weeks, and there is literally no improvement. They're still complaining of oscillopsia. And the kicker here is that patient B has been incredibly diligent. They are doing the work. So this absolutely isn't an issue of effort. So what gives? Why does the exact same prescription completely fail patient B? Well, the answer is that patient B's routine failed to target the cerebellar error signal at the correct velocity. Sure, they were moving their head, but they just weren't creating the biological demand necessary to force their brain to rewire. They were essentially spinning their wheels without ever actually turning the engine. Moving on to Section 2, Mechanism and Retinal Slip. To really understand the neurophysiology behind the VOR, we've got to look under the hood to see what actually drives recovery, starting with our baseline metric. In a completely healthy system, normal baseline VOR gain is 1.0. This means the eyes perfectly counter-rotate during head movement. If your head moves to the right, your eyes move to the left at that exact same speed. The whole point is to keep the world perfectly still, even during really unpredictable, high-frequency head turns right around that 3 to 5 hertz mark. But as you know, after an acute vestibular injury, like vestibular neuritis, this gain just drops off a cliff. On the affected side, the gain might plummet down to 0.5 or even lower. And when that happens, the eyes simply cannot keep up with the head anymore. The patient turns their head, the eyes lag behind, and boom, they report oscillopsia. That's that incredibly disturbing sensation where the visual world is bouncing or slipping. It makes reading street signs or trying to recognize faces while you're walking just horribly difficult. And that brings us to the core biological driver of everything we do in this therapy, retinal slip. Retinal slip is simply the visual error signal created when the VOR gain is mismatched to head velocity, which causes the image to literally slip right across the retina. But here is the massive paradigm shift we need to make. Retinal slip isn't just an annoying symptom that we're trying to avoid. Actually, it is the essential biological error signal that the cerebellum absolutely must receive to drive neuroplasticity. Let's trace that loop. When the patient experiences that retinal slip, climbing fibers from the inferior olive carry this error signal straight up to the Purkinje cells of the cerebella flocculus and paraflocculus. Think of a cerebellum as the ultimate error signal monitor. Once it detects that slip, it triggers parallel fiber long-term depression, or LTD. And over the course of weeks, this LTD effectively retunes the gain of the brainstem vestibular nucleus neurons. This whole pathway, this is the engine of VOR adaptation. So what's the big takeaway for your daily practice? Here is the absolute golden rule. When your patient is doing a VOR X1 viewing exercise, if they tell you the target stays perfectly clear the entire time, you know the dose is too low. If the target is perfectly clear, you have zero retinal slip. And if you have zero retinal slip, there's zero error signal reaching the cerebellum, which means absolutely no adaptation is happening. You've got to push that head velocity until the target just begins to blur. That little threshold of blur, that is your therapeutic sweet spot. Section 3. Frequency-specific adaptation. We know the engine needs an error signal, but how fast should we be running it to actually get functional, real-world recovery? This directly challenges a very common clinic practice, Think about it. Why do slow, predictable headshake drills completely fail to transfer to functional activities like walking? Well, it's because VOR adaptation is highly frequency tuned. If you're only training your patient at 1 to 2 hertz with these slow, nice, predictable sweeps, their brain is only going to adapt to low frequencies. That low frequency training leaves their high frequency gain totally unchanged. For true functional recovery, you've got to target that 2 to 5 hertz range. Real-world locomotion, like walking through a busy grocery store or quickly snapping your head around to check for traffic, happens at high, completely unpredictable velocities. It acts a lot like a head thrust, honestly. So a well-designed gaze stabilization program has to deliberately span those higher frequencies to guarantee the cerebellum is actually adapting to the real demands of their everyday life. Let's talk about how we systematically build up that demand. The most logical progression starts with mastering X1 viewing. That's where the patient fixates on a stationary target and turns their head, pushing the velocity until it just blurs, like we talked about. Once they've got that mastered, you layer in X2 viewing. Now the target is moving in the exact opposite direction of the head turn. This is huge because it essentially doubles the demand on the VOR and radically amplifies that retinal slip signal being sent to the cerebellum. When you look at the structural progression families detailed in the Australian Dizziness Clinics library, you clearly see this pathway. We move from X1 up to X2, and then we escalate the visual demand. We might add near-far switching, reading text during a turn, or throwing in super busy backgrounds like moving traffic or supermarket aisles. But the key to safely navigating all of this is constant monitoring of the patient's retinal slip tolerance. You escalate the complexity, yes, but you always ensure they are working right at that edge of clarity. Now, I need to give a really important clinical warning here. If your patient is taking vestibular suppressants past that initial 72-hour acute window, they are literally physically blocking the cerebellar error signal pathway. Vestibular suppressants dull the central nervous system's ability to detect and process retinal slip, and if you dampen the error signal, you are severely limiting their recovery. You absolutely must advocate to wean these medications early so the brain can actually do its job and learn. Section 4. Key clinical takeaways. We've covered some pretty heavy neurophysiology today, so let's distill it all down to the core actionable insights you can take back to your patients tomorrow. Number 1, remember that retinal slip is the engine of cerebellar plasticity. You've got to push that exercise dose, specifically the head velocity, until the target just begins to blur. A perfectly clear target means you're underdosing. Number 2, adaptation is frequency specific. Make sure you're spanning that 2 to 5 hertz velocity range to match the unpredictable, high-frequency demands of daily life. And number 3, advocate to wean those vestibular suppressants early. Remove visual restrictions, get them moving, and let the central nervous system receive the error signals it desperately needs to heal. If you want to dive even deeper into the clinical guidelines we discussed today, visit AustralianDizzinessClinics.com. And please, be sure to subscribe and rate this explainer series. Now, looking ahead to video 2, we'll be moving into patient selection and indications. We're going to specifically look at how to tailor these programs for unilateral versus bilateral vestibular hypofunction, and how to track those crucial recovery phase markers. Until then, I want you to ask yourself, when you hand out that exercise sheet tomorrow, are you truly generating the retinal slip your patient needs to recover? Thanks so much for joining me, and I'll see you in video 2.